All right, welcome everyone. My name is Joey Mattingly. I'm an associate professor at the University of Maryland School of Pharmacy. We're here getting ready to kick off our panel on including patient perspectives in value assessment. I have with me today Sara Emond, the Executive Vice President and Chief Operating Officer of the Institute for Clinical and Economic Review, who we'll often refer to as ICER throughout the panel. You'll hear us use that a lot today. We have Ms. Phyllis Foxworth, who's the Advocacy Vice President for the Depression and Bipolar Support Alliance, or DBSA. We have Tara Lavelle, who's an assistant professor at the Center for Evaluation of Risk and Health at Tufts Medical Center. And last but certainly not least, we have Mel Whittington, who's the Associate Director of Health Economics for the Institute for Clinical and Economic Review at ICER, who was formerly at Colorado as well. So to kind of get the panel started, again, welcome everybody. And we don't have to be too uptight. We can be kind of a little bit loose, just like we might be if we were live at SMDM. So wishing we could all be there in person so we could hang out pre and post meeting. But instead, I'll just get back up and go back to the living room whenever we get done with this. So yeah, let's kind of get started. So really, I just want to start pretty simple. Why don't we start, and Phyllis, I'd like to start with you. Tell us a little bit about what you're working on and or how maybe you've been involved in value assessment in trying to incorporate the patient input and value assessment.
Sure, thanks, Joe. I'd be happy to. DBSA is a peer-directed organization for individuals living with mood disorder, that being depression and bipolar disorder, anything along that spectrum. As part of our advocacy, it's important that we make sure that that the definition of wellness is relevant as it pertains to peers themselves across the entire healthcare ecosystem. That begins with industry and medical product development, FDA regulatory approval, clinical practice, all the way to third-party reimbursement. So you can imagine value systems are extremely important to that. But with starting with what's important to peers or patients themselves. And that's where we have been involved. And we've been involved with bringing together all of the stakeholders, those being medical product developers, FDA staffers representing regulatory approval, researchers and clinicians, as well as third-party reimbursements to help us understand and solve this problem. One of the things that we recognized early on in that is kind of like a guiding principle is that not everything that can be measured matters, and not everything that matters can be measured.
Thank you, Phyllis. And now I'll just kind of go down my screen as I see people. So Mel, if I can turn it over to you. I know recently you've made a change, but I'm sure you might share. You've been involved in health assessment, health technology assessment, value assessment for quite some time. Would love to hear how you've been involved in this process and incorporating patient input as well.
Thanks, Joey. So right now I'm currently the Associate Director of Health Economics at ICER, but this is a new transition to me within the last month. But before that, I was at the University of Colorado on faculty there, but was an academic collaborator with ICER. So we're involved with their value assessments, as well as doing other cost effectiveness-based work for other entities as well. And so my frame for this panel is hopefully as a health economic decision analytic modeler, how we can incorporate patient perspectives in there and how we do already. And so just a few of that can be, as many of you all are familiar with the ICER review process, there are extensive calls with stakeholders being patients, patient advocacy groups, and other types of stakeholders as well. And the stakeholder feedback is used to help inform comparators, treatment sequences, endpoint selection, adverse events, certain components that should be used in the modified societal perspective scenario analysis. And so these might be more, this feedback might inform more qualitatively or may inform certain structural decisions made in the model, such as comparators or treatment sequences, but is an avenue where we absolutely can inform, can use that patient feedback into the model. There's also, of course, the QALY that I know gets some heat, but what's true to the QALY is you have a utility metric and survival, and utility is a patient-reported outcome. This is a way for us to quantitatively incorporate the patient perspective into the model. Then there are also, of course, these novel value assessment methods that I think have received a lot of attention as of late. And I think that's coming out of rise of, is there a way to replace the QALY or to augment the QALY? And align with that, there's a lot of really innovative work being done. One being done at the University of Colorado. There's a center of excellence there called P-Value. I was fortunate to be involved with that center for about an hour and a half, for about a year and a half. Time flies. And so one part of my involvement with that work was holding focus groups and electronic survey with patients in collaboration with the cancer support community. So these were cancer patients we engaged. In the focus group, we asked them, hey, what really matters to you as patients when you're making treatment decisions? And overwhelmingly, it was survival, quality of life, and the ability to provide for their family. And so I think these three are captured relatively well in traditional value assessments. Our QALY is survival, quality of life. And then when we incorporate ability to return to work, ability to have leisure activities, we can include that in the modified societal perspective. Now, interestingly, we did have an electronic survey where we said, okay, look at these novel value criteria that we took from ICER's other benefit and contextual considerations and the ISPOR flower and ASCO's drug abacus, and choose some of these which you think population level decision makers, not the patient, but population level decision makers, what should they consider when incorporating these value assessments? And looking at my notes, the highest ranked were real option value. So these create opportunities to benefit from other things, maybe prolong my life enough so I have opportunity for something else. And the second was this value of hope, this chance at a cure. And so there are these novel elements that may not be well captured in traditional value assessment. And that's where we're turning to these centers of excellence like P-Value and others to really develop and test the science there.
All right, awesome. Thank you, Mel. Tara, would you like to share a little bit about what you're working on? I know you wear a lot of different hats as faculty member at Tufts, but I'd love to hear how you've been involved in this space.
Yeah, thanks, Joey. I've done a few different things that I really have been hoping is helping to advance this field of patient-centered value assessment. The first thing I started when I was a PhD student was thinking about, what are the impacts of illness on family members and how do we quantify that in a way that can go into traditional value assessments. So looking at, I did a survey of families of children with autism and asked them traditional, time trade-off questions to understand what their utilities were, how that compared to parents of children without autism, and how that could be incorporated into a value assessment. I think one of the key things that came out of that, which maybe we could talk about later, is that obviously it's not one size fits all for patient groups, right? We saw that, patients of kids that had the most severe symptoms had a very different disutility or decrease in quality of life than parents of the kids that had less severe symptoms. So, learned a lot from that project. More recently, I've been doing qualitative work and understanding value among patients with depression. And what we did there was we interviewed 25 patients, and we're really trying to understand from their perspective, what were the value elements that were important to them when they made treatment decisions. And I think what really came out from that is that when you look at a really simple measure like an EQ-5D, how does that really capture the quality of life of patients with depression? And from what we heard from patients, just the number of things that were important to them were not things that I think are really going to be accurately captured with an EQ-5D. So how do we, if we're looking to use traditional assessments, how do we really expand on those things, like an EQ-5D or other utility assessment tools? And the last thing maybe we can get into later is just started a project. And I should say that Phyllis was involved in the work we did in depression. And the most recent one we did is trying to understand from a workplace, from an employer perspective, how do we think about value? And one thing to really think about here is that most patients or many patients work, right? So when we think about value for them, how does these broader impacts on productivity and other workplace outcomes impact value? And I think that's something that we haven't really thought through as health economists, and probably there's a lot more work to be done there. But anyways, I can get into a lot of more of these things in detail as we keep talking.
Great. All right. And Sara, how about you?
Well, I'm excited. I'm excited about all of the work that Phyllis and her community are doing, that Mel did at P-Value, one of the reasons we stole her from Colorado and Kansas, that Tara is doing, and Joey, that your group's doing, because there are ways we can improve. And I think one thing that I hope is clear from looking at the history of ICER, it's been over 14 years since we've been incorporated, and for the last, say 6 or so, we've been really focused on bringing some light to this conversation about fair pricing for prescription drugs. Is we know that we can continue to improve our methods, and I hope that that's clear as you can see the evolution of our value assessment framework. And one thing we learned early on that we definitely had to do better was incorporating that patient input and that patient perspective. And so if you look, and so this is, my PR people will tell me, like, you never admit when you didn't do it great, but listen, 2015, when we did our PCSK9 inhibitor review on high cholesterol, we didn't do a very good job with the patient perspective in that. I own that. It wasn't good. And you know what? It's a lot better now. And while we still have ways to improve, and some of that is on the method side, which I hope this audience at SMDM is as excited about as I am, whether it's improving some of the metrics that we traditionally use to gather utilities to inform a cost effectiveness assessment, or all the way to brand new approaches to gathering that input and assessing it and incorporating it into the broader assessment of value. We have a lot of opportunity here to listen to the patient community, what they're telling us, what's important to them. I know we'll get into this in the conversation later, but I want to be upfront that probably the most disappointing part of my job is when we hear from patient groups during a review, but nothing in this data actually reflects what I care about. And the data that we're looking at comes from the clinical trials, from the manufacturers. And listen, the old paradigm was do what the FDA said to get approval, and then you're good. Guess what? That paradigm is over. There's a step beyond that, and it can't just be what the FDA requires, because patients are demanding that things that matter to them are captured in those clinical trials. Value assessors are demanding it. People making decisions about price and access are demanding it. And I think that's a wonderful opportunity and a wonderful place for us to be in as a community, because we're all going to benefit when we're able to actually measure what patients care about. And we'll get to that point of incentivizing the innovation that we all want, because it's what patients care about with what the drug does. So I'm really looking forward to the discussion today.
Awesome. Thanks, Sara. Yeah, I forgot to talk about what we've been working on at the University of Maryland when I jumped right into the discussion, and people at SMDM are probably wondering why the heck I'm on this panel or why I'm moderating. I was a pharmacist for several years and really realized I wanted to be more involved and learn more skills as a health economist, and went back and worked on my PhD. And as I was going through that process, I mean, I thought as a clinician, I was patient-centered. Like, of course, like I patients always at the front of, from a clinician standpoint. I didn't realize how patriarchal I was as a clinician, as I often, sort of wanted to explain things to the patients. And so actually I had really good mentors that were very involved in patient-centered outcomes research institute type grants that was developing, and patient engagement was really taking off. And as you're going through that process, I was always wondering why patients weren't involved as systematically in value assessment early on. And when I saw that PCORI had been started with a no cost effectiveness analysis, and really cost was definitely a 4-letter word in those grant applications as well. And so I used my dissertation as a way to say, hey, I want to systematically do a patient-centered cost effectiveness analysis, even though no one would ever fund that or whatever. So I sort of used that as a way to get involved and go down that path. And so it's allowed me to really, do a lot of really cool things. We're with the Center with the Patient-Driven Values in Healthcare Evaluation, or PAVE, the University of Maryland. So we have some faculty that have all sort of seen how do we merge some of the methods of patient engagement, because that's still developing too. What is the best way to engage patients? And so as we evolve as health economists too. I think those methods are kind of going along. So I'm learning, but a lot of it's kind of serendipity, you know, as things kind of work itself out. And so really fortunate. And again, being on this panel is often mainly because I've had a chance to network with the folks on this panel over the last few years. And so hopefully, you know, that kind of sets the tone so that we've can kind of jump in. And so the first topic I kind of want to start with, and we'll kind of go around, is we talk about getting patients involved or incorporated, and you know, really it seems like common sense, right? Like, well, of course, we're doing a value assessment on a disease state and it impacts patients, so why wouldn't patients be involved, right? It may seem commonsensical, but there do seem to be a lot of barriers. It doesn't really happen, or it doesn't always happen well, as Sarah mentioned. Sometimes, you know, it's not as good as it could be. And I think recently, David Kim out of Tufts published a paper demonstrating that cost effectiveness analysis, which are also often one component of the value assessment, over the history of CEA, cost effectiveness analysis, the societal perspective that Mel talked about is not done very frequently. Maybe 1 in 5 times the societal perspective will be done, and even when it is done, a lot of times it's mislabeled. So there's just a lot of limitations to capturing these other components of value. So that's sort of setting the stage with kind of where I'm going, because I want to ask, like, why is there, like, what are the biggest challenges each of you see in getting. And sometimes, and again, I want to set the definitions for folks too. When I say patient perspective, so all the health economists that are in the, in our virtual room listening, we're not talking about societal health sector perspective, like perspective from cost perspective. We're really talking about patient input. So engaging patients throughout the process. And then when we talk about the patients when we say patients, we're meaning patients that are directly impacted by the particular value assessment. Because I think what's also sometimes missed is that patients as a whole, the whole population, versus we're doing an assessment in, I think, Sarah mentioned high cholesterol. So if there's only high cholesterol patients, is it their perspective versus like everyone? So when we say patients today, we're talking about those that are maybe directly impacted by the value assessment. So, all right, I've given a ton of context. Why aren't we doing this better? What are some of the barriers? So Phyllis, can I start with you? I'd love to hear, like, what are your thoughts? Like, what are some of the biggest barriers to getting more patient input in this process?
Thanks, Joey. That is really a great question. I will share that, through my years at DBSA, I've been pleased and, and honored to attend many workshops where they were seeking the patient perspective around value and other topics such as value. And they start out by asking the patient perspective, and and it quickly then dissolves into my realization that I don't have an equitable seat at the table. And so, why, you ask? You were invited. They clearly asked for your input, and that's when I start to realize that the conversation has changed to an economics conversation, to a data modeling conversation, and I'm coming as a patient advocate, not as a data scientist or a health economist. So what did I learn from those very humbling experiences? I recognized that as a patient, the DBSA as an organization that's peer-led and for peers, that we needed to take control. And so that's, when we started the initiative to transform the definition of wellness for people living with mood disorders. And by doing that, I started convening these very small invitation-only workshops, just like I had been invited to workshops. But they were very intentional and very small, where I made sure there was equity among the scientists and the lay people, so that when we went to breakout sessions, there were not that we're not overwhelmed by the scientist's voice over the patient or the family voice. This made a tremendous difference. And we were then able to get collective input and consensus based on all the stakeholders. So those stakeholders included clinicians, researchers, medical product developers, regulatory staffers such as FDA. But there was equal inequity around the voices of people that were living with those mood disorders. But one of the things that we realized as well was that, as we spent time developing our own surveys that were peer designed surveys, out into the community, asking them what's valuable to you, what are the treatment outcomes you are seeking. We were then able to use those workshops to share that information with the data scientists and the regulatories staffers that were in the room. And then we were able the other objective of those workshops was to gather consensus around the next steps. So we've spent 4 years gathering that community input through, I said, a survey that had over 6,400 responses, a patient-focused drug development meeting that we led that's parallel path to the FDA's program. We followed that up last year with focus groups to really drill into that. And then as a result of that, last year we, through consensus with regulatory staff in the room, medical product developers in the room, clinicians, researchers in the room, we came up with a set of 4 guiding principles for our next direction. But we quickly learned, and this came from someone who was a former FDA staffer who sits on our steering team. She said, I'm concerned we're setting up expectations for the community that we are not going to be able to deliver on. What did that mean? It means that we don't have, as the community, while we were gathering that input, we didn't have the knowledge of what it's required to build a new instrument or tool. We didn't have the luxury of doing a PhD in data science or health economics. So we recognized that we need to start educating the community so that we can get their equitable input. So we know what's important to you, but it goes back to what I said before about, not everything can be measured that matters, and everything that matters can't be measured. We need to educate our peers and our community on this very idea. So we now, in our 5th year of this program, are putting together a peer and family advisory board that will now stay with us throughout the program, where we'll be able to educate them on what the data scientists and the clinicians and researchers, what decisions they're making, and have them with us getting that education so that they can have an equitable seat at the table and provide their input and comment.
Right. That's a great comment. Well, Phyllis, can I ask one of the things that I've noticed is that, patient organizations may vary from like size and number of patients, number of staff. A lot of the work I've done has mainly just been to help advise through a process where it might be because they don't have a health economist on their executive team or on staff. Right? Has that been something you just in terms of the resources may also be a challenge?
That is an excellent question. And I'm so glad you brought that up because that is one of the other areas of equity that, for example, DBSA, even though we said, all right, we have a responsibility, we can't sit here and complain. We have a responsibility to be leaders. And if we feel that we want an equal seat at the table, we need to create that environment, but we're limited by finances. We are not a large organization. We're not a large research university. There's a limit to how much we can accomplish. I mean, gathering all this input and turning it into an instrument that's reliable and validated is a lot larger than our budget. So we have to find partners, and that's one of our next evolution is how do we find those partners that for whom this is so important work that they're willing to come in and financially back us.
Oh, great comment. And that maybe segues pretty good as I turn it over to the next person. Mel, I would love to hear, because I know you've led several models over the years. You continue now, you've just been very involved from the beginning to the end and getting value assessment developed. And so what, from your perspective, what are some of the barriers and challenges you see in this process?
Yeah, I see two, and one's data, of course. And I think there's 2 types of data. There's data that is super straightforward to collect. I don't know why we don't have it for every single thing that's approved, and that's adherence and lost productivity. We have standardized methods to very straightforward, very well accepted methods to incorporate that into our traditional cost effectiveness analysis. Those methods are there. The data are often not there. I can't tell you how many times that when I have trying to figure out my model input, it's those inputs that are most challenging to find. Thinking about lost productivity, there's the WPAI survey. Put that whenever you send out the EQ5D, attach that, and we can get really robust lost productivity estimates. And then of course there's data on more novel elements, so it's thinking about patient preferences and discrete event simulations or discrete choice experiments, that is less. But I think even the data on things that we already have standardized methods to do so, we need to start collecting that. And when I say we, I don't mean ICER or one person or one organization. I mean collectively as scientists, as manufacturers, academics, we need to collect these information. And then there's the methods. I think there has been this movement to thinking about novel value assessment methods. We hear about MCPA or augmented cost effectiveness analysis. Those methods I think still need to be developed and standardized before they can become mainstream. I was really encouraged to hear that from Sara of, ICER is always looking around for what is the best, and they update their value assessment framework. And so I think, again, we, as in this royal we, everyone in this room, our virtual rooms in this conference, we need to take it upon ourselves to start testing those methods and looking into those methods and developing and applying the science. And then along with the methods piece, there's also the bit about, and when we expand our perspectives to a societal perspective, does that necessarily translate to the value-based price? What should the value of the health technology, whatever we're evaluating, absolutely see the importance of incorporating that in a societal perspective? Does that necessarily translate to the value-based price, or is the value-based price purely based on this healthcare system perspective? And just the last bit is, along with the methods and kind of more around the theory, is the threshold, of course. When you expand to a societal perspective, or when you incorporate these novel value elements, do you still use commonly cited value thresholds? Or do those increase or raise? So I think there's still a lot of great science that can be developed, and I think a lot of it will be developed by those attending this conference, which is exciting.
That's a great comment. So this is where I hope you don't mind. I like probing, so or having follow-ups. So could I ask, because you mentioned data and data availability, I think you mentioned it a bit in terms of like the community, but is there anyone specifically we should call out to say, like, should this be federally led? Should this be do I need to call my senators and say, okay, we need more support? Or is this on the private sector side? Like, what do you think? Like, what do you think had the biggest impact in terms of getting this data?
I think easiest and biggest impact is when the manufacturers are studying these drugs and conducting these phase 3 trials, add in some measures for lost productivity. And then, they already have adherence information. I'm sure that's in there somewhere. So make that publicly available, include it in your publications. Again, we have very standard methods to be able to incorporate that in traditional cost effectiveness analysis, but we need data.
Got it. That's awesome. Thank you. All right, so I'm going to keep going down the line here. Actually, I think I've got Sara now instead of Tara in the line. So Sara, I'll go to you if you have a different perspective, or if you have any or shared thoughts on maybe just barriers right now, like some of the things that that's preventing us from getting this going.
I'm violently agreeing with my co-panelists here. I mean, I think that Mel really hit well on areas of what I'll call low-hanging fruit. There are things that exist in the data set, usually throughout the clinical trial program, that would significantly improve the robustness of a value assessment. And there's a lot of different reasons that manufacturers don't always release that data. We can have an entire separate conversation about publication bias and all of these other things that happen when we were looking at data. But I think that it's important to note that some of that exists. Then there's the issues that Phyllis was so beautifully highlighting, which is, patients are identifying things that matter to them. They're seeing how they're missing from clinical trials, from value assessment. And then somehow we've decided that it's on the patient groups to then figure out how to fix that problem. I think that's an unfair position to put patient groups in. Joey, you asked the question of Phyllis, and I appreciated that patient groups come in different sizes and with different missions. And some are about peer support and peer support only. I'm not saying that yours is, Phyllis. I know you have a much broader mandate than that, right? And then there are some that are raising money to invest in early stage research for cures. I'm thinking, Cystic Fibrosis Foundation and what they did to spur Vertex to actually care about about cystic fibrosis. And when so we can get in trouble when we just say patient groups, because that is not a monolith. And so that's a really important point. But to get back to it, it shouldn't just be on patient groups to try and figure out how to fix this problem. And so I'm really happy with how we've been able to partner with groups to both identify where there are gaps, and then even in the course of our 8-month review, try to fill that gap. So in a couple of cases, we've partnered with patient groups to field a survey. There was a lack of information available in the sickle cell review that we did recently, sort of measuring the impact of crises. So when you had a crisis, on several different measures of quality of life. Either the data existed and we weren't able to get them from the manufacturer, or they weren't captured. And so fielding a survey, we were able to get that information and then use it in the cost effectiveness model. I don't think that's the paradigm that we want moving forward, because it put a huge burden on the sickle cell community in order to help, us design and then field the survey, and we analyzed the data. We have a short timeline where we're hoping to do our analysis to make sure that decision makers have the information around the time of FDA approval. And so we have to be thinking about other ways to fill those gaps. And so Mel mentioned that some of it can come from the manufacturers themselves. The other thing I would mention, and it's something that we're starting to offer now with patient groups at the end of a review, is to co-write a letter to the FDA to highlight where there are gaps in the data. Because if the FDA requires it, guess what? The manufacturers will capture it and it will be available for us to use later. And so the work that the patient community has really pioneered with the patient-focused drug development work is going to yield amazing results 10 years from now. I am super excited to do a value assessment in 10 years because of the input that the patients have been able to have with patient-focused drug development to get outcomes that matter to them into the clinical trials. But in the meantime, we need to be thinking of these sort of novel partnerships and other ways to put it together so that we have the best available data for the assessment.
Sarah, can I ask? I think that's a great point, because like people don't realize how slow policy is. Slow, and change takes time. It's incremental, right? So you made a great point. Like in 10 years, we might have an abundance of data, and maybe even we'll have all kinds of data. But what do you think might be the best way for, I don't know, filling the gaps now? Do we need to rely on, are there other organizations, are there other groups that we can try to advocate to or rely on to help fill the gap for the next 5 or 10 years?
Yeah, I mean, I think in partnership with patient groups, I think academia, there's a ton of interest in this and a lot of great work that's already happening to identify, because sometimes it can even be something like a crosswalk. Oh, I have this piece of data, but I have this method I can use to actually get to something that patients care about, right? And so we need to do more work with that in order to make the value assessment more relevant. But I want to take a quick step back, Joey, because I think the other piece of this is to remember sort of what happens at the end of a value assessment. So at the end of a value assessment, we have taken the data that are available and we have translated that into a fair price. And that price is basically what the manufacturer has been able to prove its drug does, right? In terms of length of life, quality of life, and all of these other things that it measures. If we don't have really good data at that point, that often translates into a lower price. Okay, so isn't that a perfect signal to send back to industry to do better with your data during the development process? Because guess what? If you have better data that's more relevant to patients and the outcomes that they care about, that translates into a higher price. And so while there is a gap in the data, and it's very important to acknowledge that and to work towards better, remember at the end of the day, the outcome is the manufacturer doesn't get to accrue all of that social surplus that they think that they're producing because they haven't been able to demonstrate that in the data. But if we incentivize them to actually include those outcomes in their clinical trials, then it translates into a higher price if the drug works.
Gotcha. Oh, that's a great point. I think it's also, it's a good point to share that, like, sometimes it's, statutory, regulatory, like sometimes it happens on the government side that's the really pushes, but then we can nudge, we can incentivize. I think that's a great point. So maybe there are some incentives that can maybe get, and so you have a mixed batch, right? Some that'll just meet the requirements, and then some that'll say, you know what, let's go the extra mile and get some additional data to demonstrate our product does this, and this. So that's a great comment. Tara, what are, from your perspective, I know you've been involved too with caregivers and some other components that you've looked at, spillover, just very novel things that you've been working on. What are some of the barriers and challenges that you've seen?
Yeah, I mean, from my perspective, one of the things that I've been learning more and more about is actually how to talk to patients. I think it's funny that this is something that health economists don't do very often. I remember when I was doing my PhD and I sat in on a focus group with a sociologist, and she said, "This is Tara Lavelle. She's sitting here because she wants to see what a focus group is like, because she's an economist and they don't normally talk to patients." So I think that's actually a very key thing here, is when you talk to patients, you learn what's important to them, right? And I have learned so much. First, I said, talking to the parents of children with autism, right? I mean, the stories you hear in these focus groups are things that will stay with you. I will tell you the stories from those focus groups more than I'll ever tell you my cost per QALY result from some analysis. The other thing is that, right, they will inform what we need to collect. They will help us understand what is the most important thing. I think you referenced the review that was done by David Kim. When we look at cost per QALY analyses, even when they are done from a societal perspective, oftentimes the only thing that they include is productivity, because that's the only thing that health economists have really wrapped their head around in terms of societal impact. But that's often not the most important thing, right? There's other things that are really driving the value assessment beyond productivity. In some of the work I've done in terms of, family spillover, those impacts on caregivers are really changing how we perceive value, from it being potentially low value to high value. But again, all of this has to come from, talking to patients, talking to caregivers, understanding really what's most important to them. I mean, Joey, when we talked earlier, you brought up a really interesting example about Hep C. I don't know if you want to share that in terms of how that informed your analysis.
Yeah. I'm pretty sure you and I had a conversation over the phone after you had kind of gotten started. We were talking about patient engagement, and I think we were both just commenting on how challenging it can be to go, to really do it the right way. It takes a lot of time. It's often not part of the grant that you put in, because it's a lot of time. And you know what, you actually build relationships in a really great, I feel like I have friends now that are, in different patient communities that I, just check in on. I actually had a patient that was working with me and related to Lyme disease recently, just checking in, see how I was doing. And it makes me feel like a pharmacist again, because I actually have patient relationships again. But to your point, it's not easy. And so when I was working in the hepatitis C population, I had several instances where just different things would come up and kind of click. And in terms of as a health economist, I didn't think about that. One particular instance was a patient that, when she was talking about starting treatment, she hadn't started treatment yet. And she was just sharing that she wasn't finished. She hadn't stopped using, and that means using heroin. So she hadn't stopped injecting heroin. And so she didn't see the point or the value of this $80,000, $90,000 treatment, because she was battling heroin. So when we think value, the patients may have a whole other set of issues, and so anyway, I just think that's something that we often miss. And in your comment about how challenging it may be for health economists, that was right off the bat something that I noticed. I wanted,
if I could just jump in, Joey, on that, because both you and Tara have prompted a story that I think that demonstrates why it's really important, especially for this audience, to remember that there's a lot that happens outside of the cost effectiveness model, or just sort of the nitty gritty of the methods. And so in our review of new treatments for sickle cell disease, we heard over and over from patients that when they were going into crisis and needed to go to the emergency room for a treatment, that they would change into their professional clothes because they thought that they had a better chance of being taken seriously because often they were assumed to be drug seeking because of institutionalized racism. So imagine that you're having one of the most severe, painful crises of your life, and you're going to go put on a dress or a suit in order to go to the emergency room. This struck us. This was an incredibly important part of our insights gained to patients that went into our report. Guess what? That doesn't go in the model anywhere. That doesn't. But that doesn't mean that's not important. And I'm happy to report that we had a health plan that read that insights, was struck by it, and immediately changed their criteria so that somebody with sickle cell disease was on the exception list for opioids with cancer patients and others, because they wanted to do their part in trying to take down a barrier to access, and they had no idea. They had no idea that sickle cell patients were doing this in order to go to the emergency room. So I can't say I have a win like that every single time we do a value assessment, but I think it's really important because we value things outside of the cost effectiveness model that we hear from patients, and we do have examples of how that can even move policy.
Yeah.
And Julie, if I could just add one thing that I think I think this audience of SMDM is perfect for, of these differences between patient level decision making and then population level decision making. And you know, we absolutely can have patient and other stakeholder groups inform population level decision making, but there is that difference between patient level decision making and population level decision making, and that's where we all have to work together. And you know, as an economist, I'm more involved in these population level decision making, but that's why it's so important to consider the patient, put the face on the patient, learn from the patient. And I'll tell you, you know, last week I had 4 scoping calls with patients. Those are the calls that I get most nervous for. In a virtual world, those are the ones that I'm showering for, getting dressed and ready, because these are so intimidating calls to me. These are so important parts of my day. And as an opportunity that I normally didn't have as a health economist. But then there is still this parallel. How does this influence population level decision making, where we do have this fixed budget and we have to allocate money? And so to keep that parallel between patient level decision making and population level decision making, and I just think that's something SMDM, as being a shared decision making organization, I think the audience for it is right for that.
Okay. Now I'm like, I'm wanting to go off script, and then I'm like, oh, but how do I word it right? Because this is actually a really fascinating topic, and it's like my in the different groups I've worked with, I feel like there's just a lot of challenges that come up, and I kind of wanted to hear Phyllis, your perspective on this component. When we talk about engaging patients, getting patients involved in the process, one of the things I've noticed as a challenge is like when we say equitable partner or someone that's going to actually be at the table. So I've had to defend when I've had patient input on my model, and when I say I've had to defend, I've had to, like, you know, peer reviewers in the academic journals like shoot back at me like, well, you know, what was the sample size of the people who gave you input on your model? And I want to say, like, if I had reached out to an expert health economist that's widely known in our field and asked, you know, him, which likely him, you know, like him or her for their opinion, no one would say, well, how many health economists did you sample to get their opinion? So it's not equitable, right? Like the patient that's on the panel is seen as like, and the IRB doesn't even know what to do with it. The IRB is like, wait, you're talking to patients, like you're not a participant in a trial or a study. You are an expert for your experience. So I wanted to ask you if Phyllis, if you've had trouble with, as your organization, whether as you get patients or members that are getting involved and trying to be involved, have they seen issues where it's like they're not seen as an expert, or they're just not seen, you know what I mean? Like they're kind of treated as just, I don't know, where people just don't know what to do.
Yes, I mean, I think that I personally have experienced that, and that goes back to this. Traditionally, in our human experience, we equate authority with knowledge. So when you're coming to an event and you're excited that they're doing the right thing, we want to hear from the patient community, and then you recognize quickly that you don't have the authority because you don't have the same knowledge that's at that table. And so that's where, you know, like I said, when we flip it on its head, the decision to make, we're going to flip this on its head, we're actually going to have a workshop where there's more patients and family members than there are the data scientists, and we're going to put the authority, the knowledge authority, into those patients and family members is one way to deal with it. But there is certainly a natural tension there. And I can't, share enough that we also, as the patient community, that's been my journey and my learning, that we have to own that. We just can't keep putting the blame on the data scientists and have the cops and say, well, I don't understand. Then we need, if we want a seat at the table, equitable seat at the table, then we need to, educate ourselves and educate our community. So I think that belongs with a partnership. I mean, we've heard some, I think there's some opportunities out there with academic institutions that have started taking this on. I'd love to see ICER, have a partnership with the patient communities where that was key. Maybe you get a certificate, a certificate program where someone like myself that when, I have been asked to participate as a patient reviewer for ICER, and I have provided input. I doubt that my input was as useful as it could have been had I known just some real basic stuff. And that, again, that's on me, and that's my journey, and I own that. But I think there's opportunities here around the academic and professional community, because I do believe that they want the patient input. Let's find a way to partner together so that the input you're getting is valuable.
Okay, so I appreciate that. So this might be a good time to kind of segue. Let's look at the little time checks. We're at 10:07 here, and I think we're going till 10:30 or about 10:30. Is that right?
We only have until about 10:15 actually, because we started at 9:20.
Okay, all right, just checking. All right, you always got to do time check, right? So
well, on and on, yeah.
So here, all right. So that I wanted to. I feel like we have to talk about this, just because, like, well, why are we talking virtual? Why are we not together at SMDM? And obviously, the coronavirus and COVID-19 has impacted all of us. It is, one of the biggest global health issues that we'll probably ever see in our lifetime. So I want to ask, and I kind of go around the group and ask. How has this changed? Again, aside from the virtual work and staying 6 feet apart from people, like how has this changed your perspective on how we, get patient input? How does it change your perspective on the process of value assessment? Like, again, I just kind of tee it up there because I'm just curious, like, maybe you had plans pre-COVID and now COVID is like changed everything, or I don't know. I'm just curious, and so I can kind of go down the line again. So Phyllis, mind if I start back with you? It's just easier for me to keep it straight where I've got you.
Sure. I mean, and that's a very timely question because, as I shared, our strategy was to convene with these patient engagement and stakeholder workshops. We have them in Silver Spring, Maryland, out there by where the FDA is, every November, the second Friday in November. After much consideration this year, we decided we had to cancel the event because, by its very nature, it's a workshop. It's not, so we spend time reporting out what we've learned from the patient community, and then we break into small groups and we roll up our sleeves with all the stakeholders and work. And we recognize that, you can't have 35 people, really breaking into small working groups on a Zoom call. We all know this by now, right? And so we decided that, we're just going to, rather than trying to shove something in that's not going to work, we'll postpone it. There's other things that we can be doing to move forward, but that's not one of them. And so I think that the idea of, yes, we can do surveys. DBSA continues to do focus groups. They're not as, they're good, but there certainly is something to be said for in-person focus groups versus, again, a Zoom call. So I think that we're all just doing the best we can and not holding back on our programs, but we know that in-person really lends a different type of conversation.
Gotcha. All right, Mel, what about you and your work? Have you noticed anything you like to add?
Yeah, I think this is like a really exciting and a terrifying time for scientists, where especially decision analytic modelers, we've begged for evidence to inform decision making. And now I think COVID is really an example where we are seeing that this is mainstream evidence is informing decision making. We're also seeing that outputs from our models are only as good as the data that go into it. And so when we live in this great world of uncertainty in clinical evidence, that world of uncertainty, percolates through to uncertainty in the cost effectiveness analysis. But I think what's also interesting is this element of how real time this is. And I think for me, cost effectiveness analyses have really changed in a COVID world to show the importance of real time decision making, but also this need to update. With remdesivir, we have, new evidence coming out all of the time. Now we have corticosteroids entering in the picture, but we still don't have evidence of remdesivir versus dexamethasone, and we probably never will. And so it begs this question of how often do you update your analyses? And I think I go back to, in your analyses, you can do a lot of scenario analyses. You can do a two-way sensitivity analysis of the price and either, durability of benefit or, impact on mortality, and you can get wonderful information from those results. The question then is the price going to change based on the given evidence and potentially incorporating this cost effectiveness piece? So I think this reiterates how important real-time information is needed, because decision making happens at real time. But it's also this evolving world and the need for updates, and how that updates in the cost effectiveness model, but also updates in prices. And then of course there's a whole bunch of policy and logistic issues that arise from that.
Well, that kind of calls into the question. You think it's got to be a challenge for all of us, is thinking at SMDM, so many modelers and economists that'll likely watching this. What's the value of a peer-reviewed journal publication these days? If you obviously I'm an associate professor. I'd like to make full professor one day. I need my H index to go up. I need my citations. I need I get my JAMA paper, and then I can just rest easy, right? So but is that, I don't know, have you seen a challenge in terms of knowing that, okay, I got to update this. Has it kind of made you think differently about how you want to do your models, or do it so that you can make it easy?
It actually has. I left academia. I mean, to be honest, it was this, when I was an academic in the beginning of COVID, which I transitioned to ICER September 1st. When I was an academic at the beginning of COVID, it was, okay, how can I get a brief report to JAMA out of this? How can I get this in front of the scientific community? Where is their rapid review processes so I can get this out? Now I don't have that. How can I get this in front of who it really matters? Who can see this, and who's it going to make an impact to? And so, yeah, maybe I should have started with that. I actually changed my career.
All right, so disclaimer to those at SMDM: we're not telling you to leave your jobs. It may not always work out the same way. So just disclaimer. But
and
I think
that have an impact in absolutely all spaces that you are in. But for me, it was the COVID and the real time and the rapid and needing to get this in really front of the right people that highlighted that.
Yeah, Sarah, anything you like? What are your thoughts?
Gosh, I keep telling everyone, everyone's getting hobbies in COVID, right? People are learning to sew and making bread. I was thinking maybe I should take up cross stitch and say everything's harder in COVID, because everything is harder in COVID, which I think we can all identify with. From our perspective, just helping run a small organization, Phyllis probably has experienced this too. I mean, it's just harder. Everyone's remote, and the check-ins and the Zoom calls and making sure people have what they need at home to be successful, all of that aside. If we're thinking about our work, one positive I've seen is that, at times it has been difficult to have a conversation about population health. And there are people who believe that the core of all of the decisions in healthcare really should be only on the individual level. And it's core to our social justice mission at ICER that we think about the larger population and the harm that is done when we overpay for low value services. So if anything, I think that this crisis has furthered a really important conversation about how critical population health is, and public health in particular. And the other thing I'll say is that it was an opportunity. Steve Pearson and I wrote a white paper exploring some of the ways that you can think about pricing in a unique way in a pandemic. And so the traditional way of how we've done pricing of pharmaceuticals and vaccines, our thesis was, let's throw that out a little bit, at least as the baseline, and think about these alternatives, whether it's cost recovery, whether it's value-based pricing, whether it's prizes and advanced market commitments. We explored that in a paper, again, to sort of inform policymakers who are charged with this really difficult decision of how to balance cost and access during a pandemic.
I'm glad you brought that up. Yeah, I love that white paper, at least discussing some alternatives and just thinking. Now, I hope you're not telling me I need to throw away my book, Cost Effectiveness in Health and Medicine or anything like that. I don't need to like get rid of that yet. Okay, all right. So don't throw away all my methods I've learned, but I do think it was a great point to bring up. Like maybe it's time to have some other discussions, and that sound like that's not going to end anytime soon. We've got a lot to talk about and how we value pharmaceuticals. Tara, I know as we kind of wrap. Well, what would you like to kind of add as we start closing up the conversation?
Yeah, I'll just add really briefly. I think, COVID brings up just what we've been talking about earlier, that there are just so many different definitions of value, and not to say that we need to throw all these into a value assessment for COVID, but some of my colleagues at ICER, I mean, one of the things that they've talked about in a new paper is, the fear that people have, right? Why do we value vaccines so much? Why do we value treatment so much? Because we're so afraid. We're afraid of what's going to happen to us, what's going to happen to our family members. And so there are these elements of value that really go beyond what we traditionally value. And I think that's, again, where it's just, we kind of need to have some common sense, but we need to, that's why I love, ICER now, how you have this new other benefits and considerations, because there are things that really we can't value quantitatively, but let's, at least detail it in there. Let's all just sort of have this bigger picture. And I think, again, that's where patients, and in the example of COVID, the broader population can really help to inform, what do we value? What are we trying to really improve here?
That's a great point. I love that paper too, is the fearonomics, right? Yeah, and I thought that was a great way to kind of expand on some, because I think what the original model came from, like I think Ebola and everything too. I think it's really discussing, and it's learning these infectious diseases. It's scary, and how do we talked about value of hope earlier. That's maybe the optimistic side of it, but the pessimistic side is like fear. And we're seeing, how fear can drive a lot of things. So I think that's a great comment. So I know we're sort of towards the end. Do we have time for any final comments? I can go around the panel, or do we need to sign off for time purposes?
I think we should keep going and do a few final comments.
Okay, great. Yeah. So I think this has been a fantastic conversation, and it's been, we've caught a couple of different things. So I really. Maybe here might be a good point. So, I like to think about it this, so the educator in me comes out. Okay, so now we're thinking, all right, people are watching this video, maybe on double speed if they're like my students, they double speed it. And so I sound like a chipmunk or something. I did not know that was the case, but apparently that's what they do. So, but they get to the end and say, okay, what did we taught you something? We talked about it. So what would you like the SMDM audience to walk away with this? From this call, like if you could leave them with one thing. So let's not try to give them the 10-point plan, but like what one thing would you like to hear? You would like health economists to walk away from. So actually, I'm going to end with Phyllis. So would that be okay? I start with Phyllis. I like to end with Phyllis if that's okay. So I'm going to kind of go back and start with Sara on this one.
I think that the recognition that there are important things that we cannot capture in a traditional cost effectiveness model, and that we all have to be part of the conversation about how we bring those important considerations to light, whether through novel methods and novel ways to debate and adjudicate them. But the cost effectiveness model itself is not the be all end all.
All right, Tara?
Yeah, I think I'll end with the same sentiment I started with. It's just, talk to patients. I think this is the key element that we need to start moving forward. I think SMDM is ready for this, given that the last few years they have really encouraged patients to attend meetings. They've given them scholarships. So I think that society and health economists in general are moving in the right direction, and we just really, we need to sort of further this agenda.
Oh, fantastic. Mel?
Yeah, and I think as a society, we should take it among us to test and develop new things, take risks. Let's try some novel methods. And, if we have issues, then okay, at least we know that. Let's try to explore that. And, I guess I get pessimistic when we read commentary after commentary after commentary about the issues with traditional value assessment. Well, let's test something. Let's do something.
Oh, fantastic. All right. And Phyllis?
I would share that I would ask that the society in all organizations that are involved in value assessments look at patients more than just something to check off their list. Okay, we did that. But really embrace us as true partners. And there's a responsibility on both sides of that partnership. There's a responsibility on the organizations to make sure that they're providing opportunities for the patient advocates to be educated. And there's a responsibility of the patient advocates to avail themselves and get educated. But I also think it's important that we recognize that there should be a healthy tension between the organizations and the patient advocates. That while at the end of the day, they want the same thing, but the ways in which they get there just enlightens and broadens the discussion, and it makes for a better outcome for everyone.
Oh, that's fantastic. Thank you. I guess as we sort of end this discussion, thank you all for joining us. This, I guess, whenever you watch this, so maybe 3 o'clock in the morning when you're working on a model and drinking a pot of coffee. I don't know. When would an SMDM attendee want to watch this? You think does this be something they'll watch at any random time, right? So we only heard
month of October. So yeah.
Yeah, and I don't know if they're doing any bingo. We had one dog barking. My cat did not join the call, so you can't mark that off on your bingo card. But I'm assuming I'm assuming Anker or somebody's going to put together a bingo, that they'll Zoom bingo for the meeting. So if that's the case, we had dog barking, so that's one that we had on this call.
All right. Well, thank you so much, Joey. You've done an awesome job kind of getting at some of these issues, and yeah, we've all really enjoyed this conversation, I'm sure.
Everyone to our live Q&A session on including the patient perspectives and value assessments. My name is Joey Mattingly. I'm an associate professor from the University of Maryland. And since all of our bios are linked in, we want to jump into the Q&A. So I'll just quickly introduce our panel. We've got Sara Emond from ICER, Phyllis Foxworth from the Depression and Bipolar Support Alliance, Tara Lavelle from Tufts Medical Center, and we have Mel Whittington, formerly of University of Colorado, now at ICER as well. All right, so if we can get started. Again, this is a Q&A. We can keep it a little bit informal, but if you would like to raise your hand or put in a question in the chat box, I'm happy to either, like I said, you can we can unmute you, or you can type your question in the chat box. And we thank you all for being up early, or I guess depending on what time it is where you're at. We appreciate you joining us this morning. Have everyone in? Oh, sorry, looking for hands. I don't know, would they?
Yeah, people, if they want to, can use the raise hand function that's on the participants list, or you can just enter their comment in the chat function.
All right, any burning questions to get things started?
I know some of these people here are pretty chatty, so I'm sure people have questions.
Well, while we wait, or I guess, I mean, I can maybe start a question for the panel while folks think. I'm curious if anyone on the panel had a chance to see that PCORI released a new set of principles about expanding outcomes in their new reauthorization. So the Patient-Centered Outcomes Research Institute in the United States is an organization that funds comparative effectiveness research, and for the last 10 years, it's never, it's really been like cost effectiveness, no, even cost, no. But they released new principles. And I was just curious if anyone on the panel had a chance to see the webinar or read those principles, or had any comments or thoughts about that. Because maybe, is that a space in the US where we'll start doing a little bit more patient engagement in the cost discussion?
Yeah, I've had a chance to look at them. I think it's really exciting, given the conversations that we've had with patient groups, and for people that aren't familiar with it, it now includes, we can look at patients out-of-pocket costs, other costs that would be incurred. And those are things that patients have said are really important to them, especially making treatment decisions in terms of, the costs that they incur. And I think that, by doing that, PCORI really has encompassed the broader impact that treatment decisions have on patients and also the healthcare system, in terms of decision makers, really thinking about what to cover, they're going to think about cost. So I'm happy that PCORI has gone in this direction.
And I don't know if anyone, I think there are multiple people who have attended today who also called into the live Q&A last week that Bill Padula moderated. Ankur was on the panel, and a representative from PCORI attended and specifically asked the question to, I would say, SMDM, how can we help facilitate this? And others can jump in if I'm interpreting this wrong, but it was a really encouraging question and kind of one of those, like, this is changing the field. Excuse me, because they asked, how can we support this? And we're not going to fund cost effectiveness, but we would be interested in funding elements that you could then use in a cost effectiveness analysis. And that was a common theme in our panel of what's stopping the patient perspective from entering these value assessments. And all of us said, it's the data, it's the data. So I think PCORI is now a route that can be used as a funder to get those data. And thank you to Aubrey. I think did she say Dr. Siegel? Had some comments on that. So there's a link from Dr. Siegel in the chat too that can be informative.
Great. All right, Dr. Prosser, would you like to go ahead? Let me see if I can unmute you there.
Sure, I think I'm unmuted. Can you hear me? Good morning.
Morning.
Great. Good morning, everyone. Thanks so much. I really enjoyed watching your panel the other night, and I have to say I'm really enjoying this format because it really provides a chance to kind of think about the panel discussion before the live discussion. But so I raised this question at the similar question at the panel that you just mentioned, Mel, last week. And I would love to hear responses from the panelists in this panel as well. But there has been a lot of emphasis on expanding the value framework in terms of measuring expanded health benefits. But there has not been a similar expansion of measurement of cost. And I appreciated Joanna Siegel's input that PCORI will investing in this area, but I do want to ask a specific question. So there was a statement in the panel that an argument to manufacturers to measure patient, to incorporate patient input is because it will result in a higher price and higher value for their intervention. And that is not always the case, that there are important patient effects. My research focuses on caregiver spillover effects, that there may be elements of the intervention, side effects, adverse events, difficult administration, that if there is appropriate measurement and incorporation of those aspects of the intervention into the economic evaluation, it may not lead to a higher value for the intervention. And so I wanted to highlight that aspect of expanding patient value and hear your thoughts.
Yeah, it was my comment, so I'm happy to take that, Lisa. I think that on balance, you're entirely correct, but there's so much low-hanging fruit that we're not capturing in terms of actually improving the quality of life for patients in the trials, that it's very likely that if we start doing that better, we're more likely to fully capture the upside of the treatments. So I think that you're right. If we were able to do the whole gamut, you're going to have balance there. But I mean, it is shocking to us how little data there are on things that patients care about in a lot of these clinical trials, and that the patients themselves tell us the treatment did it. Right? They're telling us, but this helped me do X, this helped me do Y. And sadly, we can't incorporate it into the value assessment because we have no data on, how was it the treatment that did it? Were they on the placebo group, because it's not tied to the intervention itself? And so I think there's a lot of low-hanging fruit here. And so I'm sorry if it came off as more flippant, that it'll always show a higher price. But I'm also trying to send a signal to industry that this is something that they should be investing in, because a lot of times we're leaving a lot of the potential value on the table because they're not asking patients what they actually care about in the impact. You're right. On balance, there'll be times when it comes down. I thought you were going to ask, if we start doing that, we start measuring these other things, and we have to have a conversation about what the appropriate threshold is, but we can leave that for another conversation.
We can, but I still want to make the point, though, that the investment from the manufacturer perspective may be differential in what patient inputs that they are measuring.
Point taken.
All right. Another question we've got in the chat box. This is from, I think, Stinky. Stinky, and again, if I'm mispronouncing that, please correct me. Thank you for your interesting symposium. I'd be interested in hearing from Phyllis on this. You mentioned some of the initiatives patient groups are taking to get a more equitable seat at the table. What steps do you think academics should take to prevent tokenism and to stimulate meaningful patient engagement throughout all levels of research? Great question.
Well,
thank you.
Yeah, that's a great question, and I appreciate you asking it. And I would just, quickly share what my journey has been as a patient advocate, working with the Depression and Bipolar Support Alliance to make sure that we're integrating the preferred peer desired outcomes across the entire healthcare ecosystem. And so, part of the background work that I would do for myself would be start attending symposiums and networking and attending conferences and being invited to have a seat at the table. And one of the things that I quickly learned about myself, even though I will just share that this is a second career for me, that I spent most of my entire career in product marketing in the information technology business. So it's like, no slouch here when it comes to understanding these things. But when I would get to the table, I would, people would certainly ask for my opinion, and then the conversation would quickly shift. And it was like, okay, check. And I will first off say that was never intentional. I'll always say that was never intentional. But then the conversation quickly shifts, check that off, and the data scientists are over here talking among themselves, and you're left with the idea of, why am I here? And you're also left with the idea of feeling very inadequate. And so then when those feelings of inadequacy appear because you're not part of this conversation, you're less likely to engage and partake. So what I was sharing at on the panel was that in order for there to be equity at the table, there needs to be equity around expert knowledge. And I feel very strongly that this is a partnership, that the patient advocacy organizations just can't sit back and say, well, this is not equitable. We have a responsibility to make sure that we are educating ourselves and that we do feel as though we can hold our own at the table. But that's where I was sharing that I think that a partnership between academia and patient advocacy organizations, you guys have the knowledge. We don't need to have PhDs in data science, but we do need to have enough background where we feel comfortable having these conversations. And I'd love to see an advancement of that type of partnership.
Great, thank you, Phyllis. We're getting some plenty of questions now in here, so I want to make sure we get as many questions through that we can from the audience. We've got Heather asks, again, appreciate the importance of incorporating patient perspectives. Huge believer. How do you think that might affect the societal perspective if the patients with experience with the condition heavily influencing the measure, perspective, values versus a naive general population, and how generic unaffected people might feel about prioritizing symptoms of the condition. So I guess I'll leave that to anyone who'd like to get in there, so we get into some of the components of the societal perspective.
Yeah, great question, Dr. Gold. And I think this is an area where us as researchers, us as a research organization can investigate and to study this, and let's look at the differences between those that experience the condition and the naive population. I would definitely not consider myself an expert in this area. I have done limited work in engaging patients and providing quantitative surveys to ask about, what do you consider valuable, or what should decision makers consider as valuable? And I think there is a lot of work to be done there related to who you ask. Is it people who have the condition? Is it the general population? And some of the work that was being done there was comparing the patient perspective. Now, the patient perspective involved in this study, the patients were individuals that had a prior cancer diagnosis. And so questions related to, is this generalizable outside of the cancer population? So still there's related to the disease area as well, but then comparing those priorities to then with the payers that were influential. And I think it just highlights all of the difference between stakeholders and what they find valuable, how much weight they attach to what they find valuable. And this is an area where we're hearing a lot about MCDA or augmented cost effectiveness analysis, where we need these weights and these maybe non-traditional value elements. And I think there's a lot of methods work that can be done there. That was my political way of not answering your question well. Too many debates watching.
I can just offer a follow-up comment, just to say that, yeah, I agree completely with Mel. I mean, this is an empirical question to some extent, and we have done work where, you know, just because you're asking about a specific patient population and let's say the impact on caregivers doesn't mean you necessarily have to go to the caregivers to answer those questions, right? So you can do hypothetical vignettes where you ask, you know, the general population how they feel about a particular health state, and Lee's has done a lot of work in this area. So I think that, you know, just because we're thinking more broadly about these impacts, it doesn't mean that we necessarily have to only go to patients. And I did some work in autism where we looked at the impact on parents of children with autism and asked them to rate a health state, and then asked parents of children without autism to rate a hypothetical health state. And actually, you know, it was one of those cases where parents of children without autism thought the health state was worse than the parents of children with autism. So these can go in very different directions. And I think empirically we need to study that. And, you know, to the extent possible, we can go to the general population and give them really good vignettes. Likely those vignettes really should be developed with the help of patient groups. We really want to make sure that they are accurate and they really do describe that health state to really reflect what the burden really is on patient groups.
Phyllis, were you going to add something? I didn't say if you raised your hand.
I was just going to share that 2 years ago, DBSA held an externally led patient-focused drug development meeting, which is a parallel program with the FDA's patient-focused drug development meetings. And one of the members of our scientific advisory board kicked the meeting off, Dr. Gary Sachs, with the comment that we don't need more treatment options, we need options that work. And so when you're looking at value, it's that if we're not incorporating what's important to the patient population themselves and relying on others to make those decisions, which has happened in the past, then how much investment are we putting into you know, the billions and billions of dollars of therapeutic treatment options that no one's going to use because they don't work? And so just strictly from a value standpoint, I think that getting directly to those people who are going to benefit from them and knowing what they want adds, you know, health economics values across the entire ecosystem.
Yeah, and before I take the next question, I was going to add back to the comment around thinking about the patients with the condition versus the naive population. So I think a lot of folks that don't have a virus like hepatitis C, so this is where a lot of my early work in patient engagement was in. If you don't have hepatitis C, we see, oh, these drugs can cure the virus. So great, we cure the virus. That's the main thing we're going to focus on. We want to avoid 20 years down the road having a liver transplant, having hepatocellular carcinomas. We want to avoid that. So we math it out, right? We start mathematically calculating the risk. Well, when you actually talk to patients with hepatitis C and you start asking them about their symptoms and putting that in perspective, they actually rank their impact on society and infecting other people as more important to them than their own physical symptoms, because early in the disease they may not have a whole lot of physical symptoms, and so like they're also thinking like, I don't want to hurt anyone else. And, you know, we call that altruism. Again, you could argue whether or not it's really altruistic, because you do benefit if you're not hurting someone else too, maybe intrinsically. But we feel like if you actually ask patients, don't always assume that, like, you know, the fatigue or the other things that they're going to feel with the disease are their top priorities. And a lot of our Hep C patients, Hep C was like the 5th thing on their list of things that they really, that they were dealing with and battling with. So I think you got to do the engagement and go in tabula rasa, right? Go in with a blank slate and just ask questions. Don't go in with preconceived kind of, you know, and that's where I think you'll have a lot of real, just open it up and let patients kind of tell you. Great question. All right, let me see where we are so I can catch up. So we've got some great comments in here. Also, a great link to, I've already clicked on the link to Dr. Whitman's paper regarding the 12 lessons learned for effective research partnerships between patients. That's a good article to check out. All right, so Scott, would you like to go ahead? Oh, and real quickly, so you're gonna notice I started earlier calling people Dr. So-and-so and Dr. So-and-so. Please don't be offended, since this is I'm not going to use doctor titles for here. And actually, that's something we do purposely at the patients program, is that when we start our advisory boards, whatever, you're going by first names. And we ask that all of our advisors kind of go with that, because we don't want there to be some type of bias that Dr. So-and-so is any more important than anyone else's. All right, sorry. So Scott, if you want to go ahead, let me see if I think you're unmuted.
Yep. So first, I just wanted to second Lisa's point about that it's not just value assessments in terms of preferences, it's also costs. Costs to families, costs to patients need to be considered. Then I had a question for Tara. Your work on autism, both on costs and on values, preferences, has that work informed any assessments of interventions for children with autism spectrum disorder?
It has not, and that's something I would love to do in the future. So if anyone wants to collaborate on that, I'll make a pitch now that I would love to do that. I think it was a really interesting study that showed, I think going back to the cost point, just the huge impact that diseases can have on costs outside the healthcare system. So for autism in particular, there was a huge cost in the school system, and that's for special education and the other services that children receive, much more so than in the healthcare system. So I do think, going back to this point of cost, it's just a really important piece to capture. But no, I haven't used it, and I would love to in the future.
Anyone else want to comment? Any other questions, or folks? We got about 10 more minutes. Great discussion so far.
I have a question that I'd love to some attendees and panel members on, if that's allowed.
Yeah, please.
The brains of these great people. So I'm thinking about incorporating costs into assessments methodologically. Sounds more straightforward to me. Any tips or past experiences on incorporating caregiver quality of life into a value assessment alongside with the patient treated, and any best practices there?
Sorry, my screen mixed up real quick. All of a sudden, Ankur replaced the picture where it's there. I was like, wait, what just happened? I thought he was at your house, but then never mind. I'm good. Go ahead, Sarah.
Yeah, it looks like Ankur has his hand up, but what I'll say for Mel, what we've reviewed in the literature in terms of how spillover effects are incorporated into a QALY is typically done just as like a marginal increment or decrement to the total QALY difference. That's typically, again, considering one caregiver, which we know for a lot of diseases is not really the full impact, right? It's for parents, it's typically, 2 caregivers, and for Alzheimer's, it can typically be, up to 3 or 4 caregivers that are really helping the patient. So not to say that that's the only way to do it. I think there's a lot more that we need to do to really think about how do we incorporate these spillover effects. But just in general, when people have done it so far, that's what they've done.
Yeah, and what we saw in food allergy, I guess, as well, trying to get at that, a lot of times, so children with severe food allergy, as their parents are answering that, but then it's still kind of a utility applied to that. I think even with the ICER assessment, they actually worked with the patient advocacy organizations to kind of even adjust their utility based on, because there just wasn't a lot of good evidence. And so that's another challenge is often you might have one study that was done and it was parents answering and it was a secondary thing, but then so a lot of times working with the patient advocacy group directly is helpful.
Yeah,
So,
I'll just quickly comment on that, Joey. Thanks. I mean, what was really interesting about that is we are pretty sure that the manufacturers of the two interventions had the data on caregiver impact, but would not make it available. I don't know that to be 100% true, but I think that's what happened. And working with the Asthma and Allergy Foundation of America, we're like, how on earth can we have any face validity with this value assessment if we don't talk about the impact on caregivers? And so we worked with them to field a survey. And we use the data from that survey to inform our model. That's not the ideal, because as I was mentioning before, you want to be able to measure the utilities in both the treatment arm and those not getting it, so you can actually do the comparator. But in the absence of that, we were really pleased that the Asthma and Allergy Foundation would work with us on this, and that utility was used in the model.
And I have a feeling that as future assessments come up through ICER that are related to asthma and allergy, they're going to have a relation, because of that relationship. That's what's critical about that, is that now all of a sudden it's no longer just an adversarial thing. It's a great thing. Ankur, you want to go ahead and ask your question?
Sure. Yeah. Thanks for the great panel, the great Q&A. You're doing a great job, Joey. Don't worry. I'm not in anybody's house. I'm in my own house. You're doing great. So I'll motivate my question by a comment I got on Twitter to our panel about value and then how it might connect to this. So it was a really simple question. Someone just asked, value to whom, when we're talking about value in the context of economic evaluation, health policy. And my answer was, in the US, half of US healthcare dollars come from public programs like Medicare, Medicaid, VA, so public dollars, and about the other half private. So think private health insurance, a lot of which come from the employer. So I said the value to whom, the whom part is taxpayers, and it's people paying into employer-based health insurance premiums. People who could have been getting that money back as lower taxes, or people who could be getting more money as wages, that money's going into health, right? And so what I see as a critical piece of the patient part is learning from the patient experience, patients who have the disease, learning about what the disease is like, what their life is like with the disease, and trying to translate that back to then the general population, which includes some patients, it includes some non-patients, it includes future patients, most importantly, and trying to see what that group is willing to give up in order to appropriately value those components. So they're giving up more money to incentivize these treatments, or they're giving up not funding some other treatments that don't have those elements. And I'm wondering so I don't do patient-centered research per se, or like non-patient, like general stakeholder thing, but is there attention being paid to that element of like, what are the stakeholders ultimately, in this case, this again, taxpayers and people putting money into the premiums, what are they willing to give up now, having learned from the patient experience?
Great question. Ankur, I guess that is open for whoever would like to jump in first, and I'd like to open it up if anyone wants to jump in, or I don't know if.
Yeah, I'll just say, Ankur, that I think this comes back to, in terms of utility, thinking about how can we elicit utilities from non-patients, and I think to your point, we need to do a really good job explaining that health state, but then like I was saying to Heather, we can go to the general population. We can ask them, how do you value this health state? And getting to your point, this is more in line with recommendations to go to the general population. And I think, that's a completely valid way to do this. And then in terms of cost, the costs are the costs, and we have to measure them from patients, from caregivers, from the broader community sectors that they're impacted in. And then the people that, are potentially experiencing that, those are the costs that they're potentially going to face. So I think, doing surveys and analyses of data sets that we can, both within and outside of the healthcare sector, is the best data to inform, what potential policies should be doing.
I was just going to add to be very careful when we talk about how do we go to the general population and then come up with a way to value a particular case. And we put out some exploratory work. We took GoFundMe pages. So if those of you are not familiar with crowdfunding, so often GoFundMe is used for new businesses trying to start up things. But apparently GoFundMe has now become a major area for people to seek out help for medical bills. We did early work in hepatitis C just to see what patients stories and narratives were on GoFundMe to seek funds. And one of the things I want to caution folks is thinking about if we get into the space of how do we value other diseases, then it becomes like this game of creating the best story, right? And then that's something we have to be careful of too. So like if we don't value someone who, you know, who's gone down the path of an opioid addiction leading to heroin, leading to hepatitis C infection, and we don't feel a lot of value, we're not willing to give up for that individual, even though again, there are other things in play. So how we go about that methodologically, we have to think about, which I think is also the great point about versus those who have the disease, impacted by the disease, maybe they're overweighting as well. So I think it's a great question. I just want to, we're stepping into some grounds, we probably have to be really careful because there's probably a lot of unintended consequences in how we assess that. Great question. Anyone else want to jump in there? Got a couple minutes left.
I might just add, when I was at the University of Colorado as part of the p-value work, the purpose of p-value is really to engage stakeholders to inform value criteria. And the infographic that was created, as Ankur points out, we had a patient stakeholder, and then we had a plan member stakeholder, and then we have innovator, provider, et cetera. But I think to keep in mind that there is this difference between a patient and a plan member, both of which may be influential in informing these value assessments.
Great.
Joey, I just echo what you had said, that I think that as a society, we have to recognize we have to recognize stigma. It exists. It's very real. And so when we're making these ethical decisions, you know, we have to suss out what is the stigma behind the ethical decision that we're making. And I can just like start writing off a whole host of conditions that aren't even mental health conditions, where stigma of our society and the values of our society is associated with stigma, say that individual is not worth the investment because they're not taking personal responsibility, when in fact it's a very real medical condition.
Great comment, Phyllis. And I was just going to add to maybe one of the things I think that comes up is that we often assume if we ask patients, this is why I encourage folks like Ankur, yourself, other economists that say, well, you know, I don't do patient-centered work. I encourage you to talk to patients. Like you'll be surprised. You go into it thinking that, oh, the patient's going to act like an economist and they're going to do the things that are in their best interest. A lot of times you'll see, you know, humans act irrationally, and right, as we say in economics, they often may advocate for, when you explain things like, well, premiums will go up, or you explain like this will impact other people, you'll be surprised with their answer. I don't think it's always totally just self.
There's an inherent tension there though, because once you are the patient, you want full coverage for your condition. But the money is coming from people who are not yet the patient. They might be the patient. And so I think it's important. I think we can learn a lot, but you can't place the full value based on the people who have the condition in a scheme where it's based on insurance.
All right, we'll definitely continue that conversation over Twitter. I'd love to, and hopefully maybe I'll talk you into setting up a patient advisory board for one of your projects. That'd be fun. So I know we're at time, right? So I'm assuming, was it 9:55? I feel like we're going to get the mic pulled from us.
Yeah, I think we're at about time.
Okay, because I did have one hand go up. So I mean, I'm not going anywhere, but is this going to shut off?
Yeah, should we just do one more question? And if we get shut off, that's okay.
Right. All right. Go ahead. Puye.
Hi.
Go ahead.
Hi. Actually, I have a comment, comment about what we do for instead of the patient. I mean, just the value that patient measures, and the information that we get from the patient is just a kind of comment. To be honest, I did some research around 7 years ago, and in that research, instead of the patient, I interviewed with the physicians, but specialists who visited the patient in different states. And the patient's value, based on their opinion and their perspective, was significantly different from each other, just because they visited the patient in different stage of the disease. And I think that would be applicable to caregivers, and also, as was discussed, to the people who are in the society but have not suffered from that disease yet. And I think it was a great comment and a great point. But I wanted just to bring this question that have we considered any kind of, have we defined any kind of standards to measure in a certain time of the disease the patient's value, or kind of, any kind of caregiver or any other person's opinion on that? Thank you.
Great comment. And I'll open up to the panel. I didn't know if Phyllis, is that one you wanted to respond to, or Tara, or who's unmuted?
It's a question that we should, about different stages of the disease.
Yeah.
I think this is a really important point, and we have to recognize that there's a lot of heterogeneity in patient populations, and the impact of the disease is going to impact them differently in terms of different stages. When we looked at, heterogeneity in the autism population, we saw very different impacts on caregivers and how they assessed also the health of their children based on the severity of their symptoms. So it's something we really have to pay attention to, and we have to define these health states to be very specific to what we're measuring in terms of the patient's severity of disease and, the stage of the disease that they're at.
Anyone else? And what we saw in hepatitis C for patients who were still using heroin, they actually saw less value in seeking out treatment while they were still using heroin. They didn't see the point. So, understanding the patient's experience, I think you can start thinking through a lot of these things. That's really interesting. All right, so we are pushing 10 o'clock. I don't want to keep anyone from other amazing sessions at SMDM. So I certainly want to thank our panel. Thank you to Phyllis, Tara, Mel, and Sarah for all that you do in continuing this great work and advocating for how we can improve methods and think through this. And thank you all at SMDM. Let's keep the engagement up on Twitter and social media and other things, and we'll stay connected even though we're not together physically. It's like you're all in my house this morning, so that's cool too. So thank you, everyone.
Thank you.